He found that these rays can pass through objects, and subsequently Henry Becquerel and Marie Curie and Pierre Curie, they found gamma rays. And next year, Emil Grubb, who was a student in Chicago, he persuaded his professor to try radiation on advanced recurrent breast cancer patient. So pertinent to today's talk, it is very important that radiation was first tried on a breast cancer patient only. Patient's name was Rosalie, and and the patient got significant benefit. And then era of radiation therapy started, and with the X-ray tubes, radium tubes, and all, and not only in cancer, for every possible disease, radiation therapy was started to be used. But nobody knew actually how much exposure to give, as it was a very new branch, new thing, and how many times to give. So all was very empirical. In 1906, around 10 years after the usage of radiation in cancer, it was found by Claudius Regaud that the same biological effect could be gained if the radiation could be divided into small doses. And before that, actually, like as I said, that everything was empirical. Radiation was, given on the whims and fancies of the doctors, because nobody knew actually. So Regaud actually was pivotal in establishing that if it could be given in small doses or fractions daily, then it has the same biological effect. He did his experiments on the bull or ram's testis, that the radiation was used for sterilization of these bull. So he found that if those doses could be divided over the period of time, then without causing excessive skin reactions, sterilization could be achieved. So to spare the effects on normal tissues, the fractionation started. And initially it was because it was very superficial X-rays and all. So the predominant or most troublesome side effect was skin reactions, because there was no skin sparing effect of the radiation. So whatever the dose limiting or most limiting factor was skin reactions. So fractionated radiation therapy started, and it was typically for 5 days a week, for sort of daily, because Saturday, Sunday is off in Western countries, and today, like, it is off for today only. So it was typically daily for five days a week, and for 5 to 7 weeks, depending on the cancer or depending on the setting. So Henry Cottard in 1934, so he published first time results in Lancet that 45 patients with advanced unresectable laryngeal cancer were treated with fractionated radiation therapy, and he found 22% cure rates. So he started his studies and in 1920s, and then he published the outcome data in 1934. So dose response relationship was also found, that like how much dose to be given, and that. So it was found that if doses were given in 2 gray of fractions, then there was exponential cell kill, and almost for 50 to 60 to 70 gray, depending on the tumor type, were needed. So in Douglas and Fowler from UK, they were doing experiments actually in vitro and in vivo as well, in mice and in some cancer cell lines, that cell kill was directly proportional to the dose. So cell kill was like if alpha was a constant for dose. Previous to the experiments by Douglas and Fowler, it was used to be assumed that cell kill was only directly proportional to the dose. But they found that there was some damage accumulated from previous doses. We are talking about fractionated radiation therapy. So there is some effect directly proportional to the square of dose also. So there are 2 components, linear component as well as quadratic component, that the dose that some effect is added from the previous exposure. So there is actually component beta into dose square. So cell kill is equal to this is exponential effect, alpha dose plus beta dose square, and so the alpha by beta concept came. If alpha by beta is more, there is more sparing effect of fractionation, and if alpha by beta is low, so there is no sparing effect of fractionation. It means that the linear component is not that much, and there is not much effect of fractionation. So this LQ linear quadratic equation, this thing is this philosophy is now most commonly used in our practice, and it has been validated in clinical studies as well, depending on the tumor type and all. Now we follow that, as in prostate cancer and breast cancer. James Arnold, who was student of Jack Fowler, actually, he observed through their experiment that alpha by beta ratio of breast cancer was 3.6. So he was pivotal as back in the 1982. He was pivotal in planning hypofractionation trials in breast cancer. So in 1982, he planned, and then first hypofractionation trial, like the START pilot trial from UK, it started in 1986, and then it went on till 1998, and there were three arms. There were two arms of 13 fractions, 42.9 gray in 13 fractions, or 39 gray in 13 fractions, and one which was conventional 50 gray in 25 fractions. And he found subsequently that there was no difference, but still there was much apprehension of use of this thing in daily practice. Then START A trial was used, actually, that 41.6 gray in 13 fractions, 39 gray in 13 fractions, and then START B trial was used. START B trial was used, 40 grain 15 fractions versus 50 grain 25 fractions, and overall it was found that there was no significant difference in loco-regional relapse at 10 years. Actually, all these trials took so much time to complete, because anyway the difference, the incidence of loco-regional relapse is very low in breast cancer. So to detect any benefit or to disregard any benefit, the longer follow-up was really required. So there was no significant difference in both of the arms, and there was moderate to marked breast induration, telangiectasia, breast edema were actually significantly less in 39 gray or 40 gray arms as compared to 50 gray. So it shows that it also confirms that alpha by beta of breast tissue and breast tumor as well low. And so there's no much advantage of doing fractionation and giving conventional fractionation. And there were other trials from other countries, like from Canada, similar trial. It was started in 1990s, 42.5 grain 16 fractions versus 50 grain 25. And one Chinese trial, it started later on, and one Danish trial also it started. All these trials also confirmed that 40 grain 15 or 16 fractions was equivalent to conventional fractionation, and more than 10-year follow-up data of around more than 7,000 patients have been published, and now 3-week schedules are the standard of care in around the world, and in most of the places in our country as well. Now, encouraged by this, actually, one trial, FAST trial, was started in 2004, based on the success of the START trials, and it was tried that if we could hypofractionate more. So FAST trial was started, and there were also 3 arms, 28.5 grain 5 fractions. It was sort of once weekly, and 30 grain 5 fractions once weekly, and compared to 50 grain 25 fractions. So normal tissue effects were again lower, but the lowest were 28.5 gray in 5 fractions, and there were very low loco-renal recurrence rate at 10 years in the tune of less than 2%. So encouraged with this, like to shorten, because it was these in fast trials the treatment were given once weekly. So it was hypothesized that rather to shorten the whole treatment in 1 week rather than giving once a week for 5 weeks, if we can do it fast forward way. So this trial was started fast forward. It was started in 2011, and there were again three arms: 26 gray in 5 fractions daily, 27 gray in 5 fractions daily, or 40 gray in 15 fractions. So it was done in 47 radiation therapy centers in UK, and 1,300 odd patients were treated in 26 gray in 5 fractions arm, and similarly in other. So around 4,000 patients were there in the study, and the recurrence rate was again less than 2%, and there were moderate or mild normal tissue effects in around 11 to 12% of this arm, 26 gray in 5 fractions, and around 10% in 40 gram, which is now standard of care. In 2016, acute skin toxicity or results were published by Brunt in Green Journal, and it was found that even acute skin toxicity were the lowest in 26 gray or in 5 fractions arm, and 5.8%. These are more in 9.8% in 27 gram and 13.6% in 40 gram. So even skin toxicity was the lowest. And then in Lancet Oncology, the results of efficacy and the late normal tissue effects were published. And I'm now telling about some background of this. This study was aimed to identify that 5 fraction schedule if delivered in 1 week was non-inferior in terms of local control as compared to 15 fraction regimen. So as I told that like 47 radiation therapy centers and around 4,000 patients were included. So patients were divided into one of these three arms. So primary endpoint was ipsilateral breast tumor relapse. So assuming 2% 5-year incidence of ipsilateral breast tumor relapse for 40 gray, non-inferiority was predefined as less than 1.6% excess. So normal tissue effects were assessed by clinicians, patients, and photographs also. And contouring was done, and patients were treated, with tangential fields, and it was edged. It was trimmed. PTV was trimmed 5 mm from the skin surface and 5 mm from the lung and chest wall interface as well, and 5 mm from the posterior beam edge. And 10 mm from the superior and inferior beam edges. So, and heart was blocked with MLCs, as is shown in the figure. Heart was blocked. Like here. So to reduce the doses to lungs and heart, this was done. The MLC shielding of the heart was done. So there were 3 arms, as we know, and those constraints were actually given for, though it was forward planning IMRT sort of thing, and the lower limit which was mandatory for that V95 should be more than 90%, though preferable was more than 95%, and for upper limit for high dose regions, V105% should be less than 7%, 107 should be less than 2%, like not more than 2% volume should receive more than 107%, and dose maximum should be less than 110. That hotspot Dmax should be less than 110. And in control group, the volume of ipsilateral lung receiving 12 gray should be less than 15%. That V12 should be 15%. Volume of heart receiving 2 gray and 10 gray should be less than 30% and 5% respectively. So that like volume of heart receiving 10 gray should be less than 5%. And for test groups, the volume of ipsilateral lung receiving 8 gray should be less than 15%. So because here, there was higher dose per fraction. So the volume V8 actually it is 15%. There V12 was 15%, and volume of heart receiving 1.5 and 7 gray should be less than 30 and 5%. So as I said that it was given with tangents, and MLC was allowed for to shield the heart and lungs. And yeah, tumor bed boost was also allowed, as depending on the preference of the center and the need of the patient and all. And boost was given maybe with 3D CRT or SBRT, like whatever, and by preferably with mini tangential means. And for treatment verification was required for each fraction in test arm. There was tolerance of less than 5 mm, but preferably for less 3 mm tolerance. And best practice to correct all the systematic errors, to correct all displacements, and to do portal imaging or and to correct within the tolerance. And for photon boost, like conformal portals and or mini tangents, or whatever was available was allowed. An electron boost was also allowed, and it was verified by visual matching daily on the skin marks, as is done usually. And in this trial, in vivo dosimetry was to be done on first day. So patients were assessed by clinicians also for relapse and normal tissue effects, and after 12 months also late onset normal tissue effects were studied, and particularly for symptomatic rib fracture, lung fibrosis, and ischemic heart disease, because there was so large dose per fraction was given, and that too also within a week. So it was apprehended that maybe there were late effects in the form of cardiac, lung, and bony. So in patient-reported outcome sub-study, like questionnaires were given to the patients and related to the effect on the heart, and photographic studies were also done, baseline at 2 years and 5 years also, to see for the cosmesis. So there were 4,000 patients, and it was actually very well statistically designed with 80% power and one-sided alpha 0.025, and with to detect whether there was an increase of 1.6% of recurrence in any of the experimental arm. So around more than half of the patients actually were, they gave their patient-reported outcome studies, and they agreed for photography studies. So between 2011 to 2014, more than 4,000 patients were treated almost equally in the 3 arms, and with the median follow-up of around 6 years, there were 31 ipsilateral breast recurrence in 40 gray group, 27 in 27 gray group, and 21 in 26 gray group. So it is actually, and statistically, these were equivalent. So hazard ratio was it is very important to say that in 27 and 26 gray group, though the study was designed for non-inferiority, but it was found to be superior, that there was even lesser ipsilateral breast recurrence. So the hazard ratio was 0.86% in 27 gray, and even but more in 26 gray group. So it is not known that why in 26 gray group there is more hazard ratio or less more hazard ratio, or we can say that why in 26 gray group there are even less recurrences as compared to 27 gray group. So as I told that in 40 gray group there was 2%, in 27 there was benefit of 0.3%, in 26 gray group there was benefit of 0.7%, and it was statistically quite significant for both the arms. So boost was given in around 25% of patients. Of this, majority was given in conventional fractionation of 10 gray in 5 fractions, and in a quarter of patients 16 gray in 8 fractions. Oncoplasty had been done in 3% of patients. Reconstruction was 0.5%, and there were only very few 2% of patients less than 40 years, and so and majority of patients were ER positive and HER2 negative, 80%, and only 3% of patients had received neoadjuvant chemotherapy and 27% adjuvant chemo. So we see that there was less breast cancer related events. Blue line is 26 gray. It is the lowest at 7 years. So regarding cosmesis and other normal tissue effects, it was found that in 40 gray arm, it was of the breast or chest wall, clinician assessed effects were 9.9 or around 10% in 40 gray, 15% in 27 gray, and around 12% in 26 gray. And across all clinician assessments from 1 to 5 years, and odds ratio for these effects was 40 gray, 15 fractions were 1.55. Though it means the late normal tissue effects were a bit severe. There was odd ratio of around 1.55 for 27 gray and 1.12 in 26 gray. Means from 10 to 12% as compared to 40 gray versus 26 gray, and 10 to 15% as compared to 40 versus 27 gray. And patient and photographic assessments showed also higher normal tissue effect risk for 27 gray versus 40 gray, but not for 26 versus 40 gray. And very low rate of cardiac events, rib fracture, and symptomatic lung fibrosis. And there were these clinician assessments: breast distortion, changes in breast appearance, breast shrinkage, breast induration, and all hardness. All these were actually not different in 26 gray versus 40 gray arms. And these were telangiectasia, edema, and other effects. And even in changes in breast appearance, photographic changes in breast appearance, there was marked in 40, only in 2% patients in 40 gray arm versus 19% in 27 gray arm at 2 years, and 13 in 26 gray arm. And if we see at 5 years, there was only 1% in 40 gray arm, 9% in 26 gray arm, and 13% in 27 gray arm. So there was actually definite a bit increase in this photographic breast appearance in around 10 to 13% of patients in this ultra hypofractionated arm as compared to 14-15 arms. And so whether the patients were referred to specialists for radiation related late effects. So for lymphedema, around 6.6% patients were referred for 40 gray arm, 8.9 in 27 and 7.7 in 26 gray. So not much difference. And for breast surgery, any subsequent surgery, also not much difference. For cardiology, also not much difference, 0.4% in 40 gray arm, 0.7% in 27 gray arm, and in 0.5% in 26 gray arm. And similarly to all in for other specialist referrals as well. So symptomatic rib fracture was 0.4% in 40 gray arm, around 1% in 27, and 0.9% in 26 gray arm. And symptomatic lung fibrosis was also very minimally increased, and ischemic heart disease was the rates were similar. For left-sided cancer patients, in 40 gray arm there was ischemic heart disease 0.4%, 0.6% in 27 gray, 0.2% in 26 gray. So in 26 gray arm it was a bit lesser, though statistically it doesn't mean anything, it is equivalent. So 26 gray in 5 fractions was non-inferior and safe in terms of normal tissue effects for 5 years, and is now becoming the standard of care in many centers. Though few people are still apprehensive, but as the data shows that it is safe, and in terms of late effects, it's also very safe. And in normal tissue effects, number of moderate or marked events or of breast distortion, shrinkage, induration, telangiectasia, edema, and discomfort, these were not statistically significant. Like in 40 gram, it was 10.6%, and in 26 gram, 12.2%. In 27 gram, though there was around 16%, these breast effects were reported. So limitations of the study were that very low rates of cardiac events were there. So maybe the longer follow-up study outcomes, maybe at 10 years or 15 years, may shed some more light on this. And because majority of patients were ER positive patients, so we don't know whether this effect is actually equivalent in other groups as well, in ER negative or HER2 positive or triple negative or whatever. We don't know whether this was as effective in other settings also, because ER positive group is in itself is a very favorable group. So synchronous boost regimen was avoided in this group, despite current interest that if we could give more boost, even after 26 day in 5 fractions, we can give boost or not. So should we wait or not? So though we have level 1 evidence that which supports the 26 day in 5 fractions as the standard treatment option. But there are some actually apprehensions that some people say that because late side effects are not better as compared to 40 gray. So, and maybe with the time there may more later effects may come with subsequent follow-up. So we may need to wait. So similar and data from lymph node for radiation therapy for if we can give for brachial plexus and effects on that and were to be seen. And some people also postulate that if doses less than 25 grain 5 fractions can be given or not, whether these would be similarly efficacious in terms of local control or not. So now I would be talking something about follow-up. Now after treatment, after radiation therapy, how to follow up the patients. Though investigations are routinely done at many centers and by many clinicians, primarily to catch early recurrent disease. But at our center, we don't do it routinely. There are 2 phase 3 randomized trials with more than 10 years follow-up, which have shown that there is no survival advantage in doing imaging tests routinely, like maybe X-ray, ultrasound, CT, PET scan. Some patients are also themselves apprehensive, so they ask the doctors to do tests, and some doctors are also apprehensive or whatever they tend. But in our experience, and as evidence also suggests, that there is no benefit of doing the test routinely, rather than there is some actually disadvantage, because sometimes very insignificant finding comes up and the patient is disturbed, and and financially also, and much of the effort goes on in pursuing that. For example, sometimes PET scan is done after the treatment, and PET scan shows there is some node in mediastinum which is showing some uptake, and then you can't leave it. Then you are going behind it and you are doing US guided FNAC or biopsy, and most of the times it comes granulomata, so maybe insignificant, and this doesn't help any much. So what is recommended? That clinical breast examination is recommended 6 monthly. We call the patients every 6 months, not before that. And any imaging to be done if patient is symptomatic, like for dyspnea, for any pain, bony pains or whatever, or if maybe there is increase in edema, lymphedema, so to see if there are some lymph nodes or not, or if there is anorexia, weight loss, anything. Though for some high risk patients, maybe with very high nodal burden, and especially with internal mammary nodes, and especially like in triple negative breast cancer, where we see that like patients, there were internal mammary nodes before, and the internal mammary nodes could not be removed, cannot be removed. So after chemotherapy, we give radiation therapy, so to see whether these have come up or not. And especially in TNBC, some people suggest to do the imaging, and Also, if the patients were oligometastasis in the beginning and those were treated with radical intent, so those patients may be actually candidates for routine imaging. Yeah, if the patients are BRCA positive, then emphasis on sex should be there for the symptoms for second primary, like maybe ovarian cancer, endometrial cancer, and patients should be asked about any, especially in postmenopausal patients, about new onset uh, postmenopausal bleeding. This could be because of tamoxifen, if tamoxifen was going on, or maybe endometrial or ovarian cancer. So counseling for screening for family members should be done in case of BRCA positive patients, like for male members, like brothers, like for prostate cancer, screening with PSA should be done, and for daughters and sisters, screening for breast and ovarian cancer at least should be done. So compliance with anti-hormonal agents is very, very important, because many patients actually leave the anti-hormonal agents in between, and we know that in ER positive patients this is very crucial. Nowadays, actually, the chemotherapy in ER positive patients, the number of cycles is being reduced for good risk patients from 6 to 4 cycles. So relying on the premise that anti-hormonal agents would be sufficient to cover for that. So counseling should be done for any fear of relapse. At this time, there are around more than 40 lakh breast cancer survivors in the United States. And in our country also, the number of breast cancer survivors are also increasing. So there is no much fear of breast cancer as was there around 10 years back in our country also. So many patients are themselves, they know many patients, many known breast cancer survivors. So it would be good to have some support group meetings so that patients don't feel very fearful of the relapse and that. So contralateral mammography should be done actually every 3 years, though there are different recommendations in different countries, but it is usually accepted that it should be done every 3 years. For high risk patients, it can be done otherwise also, like if there's strong family history or BRCA positive and all. MRI as indicated for dense breast, or if there is a strong family history, MRI of contralateral breast can be considered. Thank you. So I am open for any questions. You can please ask.
So thank you so much, sir. It was an interesting, and you have told us in very detail, and there are questions also in chat box. So Dr. Vijayalakshmi is asking why this fast-forward trial has not been implemented in all centers. I think you have covered, but again,
yeah,
can answer, yeah.
Yeah. See, there is actually, in our fraternity and in all medical fraternities as well, there is quite bit apprehension to accept any new thing which comes off, and especially which is contrary to the long practice. So as I said that these trials were started in 1980s, and still hypofractionation, as I remember that like 14, 15 or whatever was accepted just for 5 to 7 years back, like after 2015. Though in Tata Memorial Hospital, we used to do some 45 in 20 sort of middle sort of hypofractionation based on the results of based on the start trials. But majority of the times, many people remain apprehensive. So I think because this is relatively new, and like 14-15 trial also actually took around 8 to 10 years in our country to be accepted after the results came out. It was not that we accepted it immediately, like all centers accepted immediately, though now it is the standard of care in majority of centers. But as is asked that why it is not being used, it is, initial preferences and the apprehensions that maybe, or maybe there could be one reason that uh, uh, like, the patient's treatment would finish very fast. Uh, it seems a sort of palliative thing like that, because I discussed
Yeah.
with a few doctors that,
Mhm.
and patients maybe patients may think like you have not done anything, just 5 fractions or no. But whatever evidence say that it is safe, and it is as effective, and it can be given as now SBRT, or sort of like hypofractionation, is being increasingly used in lung cancer, and in prostate cancer as well, and in liver to SBRT is common. So I think with the time, in next 1 to 2 years, this should be the standard of care in our country as well.
Yeah,
Can I
you have
just,
rightly pointed out. You have rightly
Survi,
explained everything.
Survi,
Yes, sir.
can
Yes,
I,
sir. Yeah. Dr.
I want,
Stalin, sir, is there. He is, yeah, sir, please.
Good evening, sir.
good evening, Amit. So, Amit, a couple of questions. First, I'll answer this question about the 5 fraction treatment, 26 and 5.
Yes, sir.
So, I'd like to tell you that in this country, there is one trial going on that is spearheaded by the Tata Medical Center at Kolkata. It's called the Hyport trial, and they are testing 40 and 15 versus 26 and 5.
Yes, sir.
And the reason is, and the reason is that, like everything else, our disease patterns are different. The proportion of early, intermediate, and relatively locally advanced disease post-mastectomy, large operable and LABCs that are conserved or undergo mastectomies are considerably higher still in our country compared to the West, as also the axillary nodal burden and the supraclavicular fields, the indication for treating supraclavicular fields. So, with that in mind, this trial is currently underway. And in the UK, it is currently standard for their demography, and they have a very low 5-year recurrence rate, a 10-year recurrence rate of the order of local recurrence rate of the order of 2%.
Yes, sir.
So that's one thing. So why has it not taken off? It hasn't. It is certainly underway, and this trial is happening in India currently. So it's not in clinical practice for sure, but we are looking at it. SGPGI also is incidentally participating, and my colleagues here, Dr. Punita and Dr. Shagun and Dr. Maria and others are looking at it, are participating. Okay, that's beside the point. The second point was that I wish to talk about is the 40 in 15 story. Now, Manchester was always using 40 in 15 since the 1960s. Okay, and
Yes.
both those doctors, those teachers of ours, seniors of ours, like Dr. Saroj Gupte, Dr. A.D. Singh, and Dr. B.D. Gupta, these were the pioneers. Madam Dr. Dinshaw, these were the people who came from there. They used hypofractionated regimes in both in vocal cord 55 and 15, 50 gray, 50 gray in 15 for bladder, 55 and 15 for vocal cords, and 40 gray and 15 fractions for breast were being used. And so PGI Chandigarh has a legacy of almost 30, 35, 40 years of using 40 in 15, which currently, today, after the START A and START B trials, we in our country now accept as and have welcomed it basis these randomized evidence. But certainly there is a very, very long practice and also published from Chandigarh, to the best of my knowledge. Okay, that was the second thing I wanted to share with you. The only other thing I thought I would like to clarify, that the principal reason for investigating the principal reason for investigating the fraction size, reducing the fraction size or increasing the fraction size from 2 gray to a higher dose arose from the fact that the alpha beta, as you rightly pointed out, was for late effects is normally 2. You see, as the fraction size increases,
I think sir has been disconnected. So Dr. Amit, can we take another question?
Yeah.
How much of a hot spot to be accepted, especially in hypofractionation schedules?
See, though in the trial, this fast forward trial, that the more than 105% should not be more than 5%, and more than 107% should not be more than 2%. Though, like in hypofractionation schedules, like my personal is that there should not be more than 105%, no dose more than 105, and it is quite possible. Like as we do that, it is quite possible, and we there should not be a hotspot above 105.
Okay, sir. And what about the dose to heart? Do you see mean dose, or how do you calculate? What do you do?
Yeah, dose to like the 10. We see the 10% of the heart. 10% of the heart should not get more than 30 gray.
Okay, sir. And do you see mean dose?
Mean dose of the to the heart? No.
Yes, sir, mean dose to the heart.
Yeah, we see that this 30%, 10% of the heart should not get more than 30 gray.
Yeah.
Actually, now, because we tend to shield, and this is now, yeah. So the mean dose is anyway very less. So previously, a mean dose was actually given emphasis, but nowadays, especially with hypofractionation and all, so this is like considered whether the what is the maximum dose or what is the dose of this.
Okay, sir. So another question is, in BCS patient, ipsilateral mammography should be carried out at what interval? When we follow our patient, what should be the interval? At which interval mammography should be followed?
See, there are recommendations for contralateral mammography for BCS patients. In my opinion, they can be done as for contralateral mammography every 3 years or so, and the clinical breast examination is sufficient.
Okay, sir. Thank you so much. And actually, we do yearly.
Okay. Yeah. Some people do yearly also. Some people do yearly also, and there are no recommendations for ipsilateral actually breast mammography.
Yes, you are. But because of these litigations, also we do it. So we follow it yearly, and I think NCCN guidelines, they also say to do yearly. So we do for contralateral breast, and also simultaneously we follow for ipsilateral. Yearly can be done.
You just want to add something, Dr. Rashid. Usually, clinical examination is the best examination for this type of patient after BCS. But if we see that is very any suspicious, then 6 monthly or 1 yearly mammography is sufficient, I think, in this type of patients. Hello.
Yeah, you are audible. You are audible.
Yeah, no, after a long time.
Yeah.
So thank you so much, Dr. Amit, for such a excellent talk. And I think there's no more question.
One question is by Dr. Yashwant: is tumor bed boost recommended after hypofractionated radiotherapy?
After 14-15 or after this?
After 14-15.
See, again, like it's on the personal choice, that some people they give like as in the trial also, 25% of the patients received tumor bed boost, and though like in my we tend to give tumor bed boost after 14-15, we tend to give 10 grain 5 fractions.
Yeah, we also give 10-4. In TMH also they are doing certain set of patients. If the patient is having more than 60 years of the age, grade 1 tumor, ERPR positive, everything is good, then at that time we skip the boost. Otherwise, we are also giving. We are giving. Yeah, we have to give an NCCN guidelines are also that we follow, they have also recommended. Dr. Siddhi, your question was, one question is left. Is there any trial comparing ultra short and short regimen,
especially particularly in left side of the breast cancer? I think in my knowledge, there is no exclusively trial like this one, especially for left breast cancer.
Yeah, it would be really interesting to see if there is any trial for left-sided breast cancer, because that would be really powered and to see, because I think the most important fear is heart only.
Yeah, definitely. This is the most concerned point.
Yeah.
So,
Dr. Amit, are you doing IMRT? Ma'am, I want to ask, Dr. Amit, are you doing IMRT in breast cancer?
We actually forward planning IMRT sort of thing. Forward planning.
Okay.
Yeah, but though for some patients we are doing IMRT with tomotherapy, because like patients who cannot keep their keep their arms above and for so long, and in those patients we are doing, and now we put constraints accordingly so that there is not much dose to the lungs with that.
So ma'am, Dr. Shalini is there, and he was actually
yeah, Avinashi, can you see?
Yes, ma'am. Yes, ma'am.
Can you send him request? Dr. Amit, I just want to ask whether you are doing brachytherapy practice at your institution?
Brachytherapy?
Yeah, practice at your institution?
No, no, but we are actually very soon going to start.
But definitely you are covering a large area there, all the beds, Saharanpur, Muzaffarnagar and all these beds you are covering.
Yeah. So we have ordered actually, we are going to start very soon.
Yeah, so we
can slow internet connection. So
I think we should conclude with this. Thank you so much, Dr. Amit, for such an excellent talk and covering both the most talked topic, that is hyperfraction, and least talked topic, that is the follow-up in CA breast. So thank you so much. Thank you, Dr. Rashi. Shalin sir must be hearing me. So thank you so much, sir, and all the participants for participation here. And thank you, RPG, for giving us platform. Thank you, everyone. Good night.
Thank you so much. Thank you. Thank you, Dr. Sarvi. Thank you, Dr. Rashi.